So I'll spool it back for 1 minute, right? So I was talking or trying to talk about optimal endodontic care, right? How can we achieve it? Now, let's just give it one more shot. So movement, we have liftoff. That's very good. It is interesting to think of, even though I understand that none or very few of the people here are actually endodontists. Is this where the optimal care lives? I'm not so sure. Go on again. Okay.
Is it like a word you're saying that's showing?
Yeah.
My
voice back again.
Sorry, yeah, because we haven't changed any settings. It should be good for now.
Hello, anybody there?
Yes, we can hear you.
Good, okay, that's good.
So maybe. Can still hear me, okay?
Yeah, we haven't changed
So
any
maybe
settings.
we'll jump over all the bits and pieces and bumps in the road. So this is maybe a bit unusual, but it's actually here and now. Others have some of these things already occupied. I will show you a couple of papers. By the way, this easily, because we used up 10 valuable minutes of my speaking time, maybe we can tack this on at the back. So we need to get outside the comfort zone, which is exactly what we're doing right now, don't we? So there's a universal notion of what I would think of as disease management. We like in dentistry to think that once we have performed any type of treatment, we have complete the circle and come to a success. While in reality, dentistry is never finished until the patient passes away. So if you look at the timeline here, these are a lot of things that I had to take a look at, and some of them, of course, I knew already, but some are quite out of the normal sphere, if you will, including philosophy of the 1800s and so forth. So you see the timeline here. I mean, in particular, in the last 10 years or so, there has been a lot of movement in this space, and has not gone unnoticed. So let me go a little bit more here into details. My dean at the school in San Francisco came to us and was explaining the triple aim to us. So the triple aim, essentially, he said to me, it looks like this. We improve individual outcomes, make population health better, and all of that for less money. And then I told him, if you can tell me how to do this, I'm buying into it. So there's a lot of overtones and a lot of other discussions about this now. And in fact, the triple aim, as some of us know, is now the quintuple aim, and doesn't make it any easier. Now, where does this notion come into play? So the FDI has this logo where they lead the world to optimal oral health, right? And so that's kind of the idea that I took from my work with the FDI, where I wrote this white paper on endodontics with Gerhard Seeberger, who was the president of the FDA at that time. And it is very apparent that the context is the major question here. It's very different even within one individual socioeconomic location, what kind of care you look at. And for endodontics, a typical example is if you have a lot of dentistry going on, most of endodontic treatment is a consequence of dentistry, as opposed to some other locations where open caries and subsequent pulpal breakdown is the more prominent issue. So we really have talking about here, we have to understand what the disease. Raji, if this is. Maybe I'll do this, right? So we'll observe this for another 10 minutes, and maybe then I'll call it a day, because this is wasting your time, and I hate to waste your time. We can make a recording and then do it another day, because the technology is not under my control, nor is it under Myra. So that's probably perhaps a solution. In any case, maybe we have a good time here and just let them do whatever they want. So the disease model in endodontics is quite simple. And this deals with apical periodontitis. This is this well-known, well-described, radiographically visible bone rarefaction that you have after pulpal necrosis, or at least showable in the periapical film after sufficient pulpal breakdown. And this is a historic case here. This is a prehistoric skull that you see on the right, that also, due to attrition and due to exposure just by food intake and the wear, caused in this prehistoric skull a very typical apical periodontitis lesion. Now, the problem with this is only half the story, right? If we perceive endodontic disease as the disease of the periapex, we're really neglecting the disease burden, because it's firstly a pulpal disease with microbial ingress, and you have this very typical scenario where you have inflammation, you have pulp necrosis as one of the possible endpoints, and we have relevant correlates that could be symptoms that are quite important in the daily lives of our patients. What we right now don't have is a continuous disease scale. Try to make it somewhat of a stepped disease scale, and I'll explain to you a little bit more towards the end how we can actually grade the disease possibly. In general, endodontic disease will not resolve spontaneously. Some kind of treatment is required once it has reached the scenario as it's described as pulpitis or pulp necrosis. The prevalence of pulpal disease is grossly unknown. I tried to extract some of this and asked Locke's help, but it was not really so easily possible to understand this. Let me show you some information here. These very large studies that look at oral disease burden are really not answering the question that we have. I mean, they have this notion of daily, which is associated with somewhat of a virtual scale of disease burden. And they say that almost half of the world's population is affected by various oral conditions. Among them, caries and periodontal disease, quite obviously. Indeed, caries prevalence is globally 1/3 of the population is associated with caries on permanent teeth. These teeth, if they're not treated properly, have a very high likelihood to have pulpal pain. The Casaubon papers talk about pulpal pain, but they don't give a number. Right? Apical periodontitis affects a lot of people. Whenever I talk to large groups, medium groups, whatever, I draw a line in the middle, and half of the people of the room has apical periodontitis. So let's assume the table is the middle. We're on the good side. You're all on the apical periodontitis. Okay? So indeed, this is true irrespective of the type of treatment that has been performed, because quite a few teeth have apical periodontitis if they are root canal treated. This is Segura Eguia. We did the study that's shown on the left based on cone beam CT, where we have very similar numbers. In fact, with cone beam CT, you have higher numbers than you would find in the standard periapical radiography. Almost 41% of teeth that were in this sample that had a root canal treatment had apical changes. That's a very high number. Well, let's take a look at it from a, let's say, almost philosophical approach. This is Thomas Quist's diagram. And what he shows here, green is good, red is bad. If you take a cohort of patients that have root canal treated teeth and apply different detection systems, you get different disease health breakdowns. The standard in endodontics is periapical radiography. If you take 100 patients that have received root canal treatment after a diagnosis of apical periodontitis was found, then you have 80% success, 20% non-success, right? This is the bars that you see about here. If you use exactly the same patients and perform cone beam tomography, the breakdown is 50-50. 50% success, 50% failure. This does not mean the patients are now healthier or more diseased. It just means the detection tool makes the numbers. If you use just subjective symptoms, almost every case is successful. Maybe 8% or so of patients have persistent pain. Again, the patient is not necessarily healthier or more diseased. If you take, however, molecular biology detection tools, almost every patient has persistent apical periodontitis. What do we make of it? That's somewhat of the starting point for me in this whole discussion. And this is not just me, this is a very broad quandary that the field has. So the typical contention is we have reversible pulpitis and everything can be salvaged, but we have irreversible pulpitis. Everything after that is a root canal treatment or an extraction has been challenged. So there is really no such thing as irreversible pulpitis in the modern viewpoint. This is a paper out of the Netherlands with some other authors, Walters and others, that have brought this to the fore. And the issue with this is we don't have the detection tools. This is based on symptoms. Symptoms could mean a lot of different things. And they have terms here instead of irreversible, reversible, they say initial pulpitis, mild pulpitis, moderate pulpitis, severe pulpitis, based on symptoms. However, we know that many patients that ultimately have a necrotic pulp space never had any symptoms. How does it fit into this system and how does it allow us to draw resolutions and ideas about treatment? Very difficult. So this is where Fasane came into play, and we haven't really unfortunately gotten to the product that we want to bring to market, but who knows, maybe. So the idea was to look for other technologies that can actually give objective answers of what the pulpal conditions are. And that's proves to be a little bit elusive over time, but maybe we have something. So I don't want to give you the something just yet, but keep abreast that there was something going forward. It's a bit easier to look at apical periodontitis because the imaging for apical periodontitis that could give us the answers is MRI. So I'll come back to this later on. Why is this important? This is important to get a sense of what is the risk for disease? What is the current condition? How serious is it? What is the potential for deterioration? Perio, I'm so sad to report that the periodontists are not here today, but we'll live with that. They have a bit ahead, and Tonetti is the lead author on this paper here that shows the staging and grading of periodontitis, the classification that is the contemporary model. And I don't want you to read these fine prints, but it has essentially three elements, right? Staging is the severity and the extent of the disease, and is signaled by the amount of bone loss. And the grades will talk about progression or likelihood of disease severity increasing or regressing perhaps. And that allows us to change the therapy or tailor the therapy a little bit more specifically to a patient. Remember, the talk is about optimal care, right? In endodontics, we're using a shotgun approach, really. The care we provide is largely similar. We do vital pulse therapy sometimes, but for the most part, we do root canal treatment. So Perio has this beautiful diagram. This is Mark Bartlett and our own Sasha Ivanowski. And so what we're looking at here is changing treatment options from a purely reactive model. And in endodontics, the reactive model is the toothache dentistry, right? And this is very broadly being utilized. So can we do this differently? Okay. And this is the introduction to P4 medicine, of what I hope becomes P4 endodontics at some point. This is not a new concept. Hood is already in the early 2000s associated with this. But I just want to give you the highlights here. This is a proactive care model rather than reactive, and looking at wellness rather than the absence of disease. And that's, I think, really a shift in dentistry. As four key areas of interest that I will discuss in some detail. But because this is an American system, and there's also a business aspect to it, you know, they know exactly how to make money. You know, and in fairness, the sophisticated consumers of today will be amenable to generating demand. So we have to be a bit mindful of what that actually means. So this P4 system exists out of four notions. The predictive nature that allows us to understand disease outcomes, of course, preventive nature that allows us to actually, even before any disease symptoms or any disease physically is present, say, okay, what should we do to avoid this kind of scenario? And it's personalized, it's very much individualized. Tricky. I will explain a bit why this is possible, or to which extent it's possible. And what I think is exceedingly important is the participatory portion of this. Very simple example. We need patients to come back for a recall appointment. Patients that are completely symptom-free are not very often seen in our clinic, unfortunately, for recall appointment. They have a very hard time, but they are making their own destiny and in certain conditions. Now, what is the endodontic risk? So what do we want to predict? The likelihood for pain to occur after root canal treatment is fairly low. Fairly low. Everybody who is a dentist here has probably done what I have done. You look at the tooth that is root canal treated, has an apical radiolucent area, has been there for 5 years. You tell the patient, this is a risky scenario. You will have an abscess at some point in time. And the answer is no, you won't. The risk for that to develop is very low. Okay, over 20 years, maybe 5%. So what's the risk of losing the tooth? If everything is good and well cared for, the risk is also fairly low. What is the overall risk for some kind of severe health event? It's unknown. That is what we need to take a look at. Is this a cardiovascular risk factor? Maybe it is. Perry thinks it is. Is it a risk factor associated with other systemic diseases? Possibly. Now, I will abbreviate this a little bit in the interest of time, but it's clear that emergency presentations are a major driver for patients to come to the dentist, not only in this building, but also in private practice. Out of Adelaide, and this is a Australia-wide survey, and out of this particular subset of about 6,500 patients, it turns out that 1/5 came to the practices on private practice for emergency treatment. And the typical presentations were trauma and pulp and periapical disease. So this is a health burden that is evident in our community. It's also a financial burden. Interesting enough, older uninsured males are more likely to attend for emergency services. maybe not you, maybe me. Okay. So some risk indicators are described for attending emergency services, and these are both clinically and social. And preventive measures may reduce emergency room attendances in private practice. Now, this is a very interesting paper, also out of Australia. It's actually from Melbourne University, Victoria U and Eric Messer. A bit tricky to understand this. What they have tried to construct in the pre-AI times is a deterioration risk score, meaning you have an existing periapical radiolucent area that is apparently not healing, but what's the likelihood for this to get worse locally, radiographically over time? And I spare you the gory details of the statistics here, but they have this 5-level risk score constructed based on 4 factors. How long ago was the treatment performed? Is the tooth currently painful? Is there a sinus tract? And what kind of apical radiolucent lesion size do you have? And the model performed well. It's not surprising. You can make it work. And I have to learn a little bit more about this type of approach. But for me, it's not surprising. If you have a limited number of cases, you make a statistical model, you can train it sufficiently even without AI, as I was saying before. They make a very definitive statement saying apical periodontitis is compatible with health. And, I don't know. Overtreatment is a question. And this is some insights here. Overtreatment is a question because if we are starting, after I said there's a 50% of everybody has apical periodontitis, after we're starting in the shotgun approach to treat everybody, we have nothing else to do. So that cannot be the right approach. We need to learn more about this. So what other risks do we have? We'll just ignore this for a moment. Can you actually? Yes. So is there life-threatening risk to apical periodontitis? For me, that's the major question that I have really. Last year, there were 72 or so females that were killed by their domestic partners. That's a risk. Are we still getting married sometimes? We do, right? So road cyclists, about 200 road cyclists were killed on Australia's roads. Are we still riding the bike? Yeah, we do. How many people have to die from apical periodontitis for us to say this is an unacceptable risk? Is 5 too many? How about 10? Should the number not be 0? Right? In the US, there was a case where a young boy died, an African-American boy in Washington, D.C., Devontae Driver, and the whole country was in turmoil for that because it was clearly a failing system. You can say this is a bit of the case also. I picked this study out of Finland, And the issue is avoidable hospitalization. In Australia, per year, there are about 80,000 avoidable hospitalizations for oral conditions. A lot of kids, right? So the incidence of this significant event is actually increasing, not only here in Australia, but also abroad. Oftentimes, apical abscesses from endodontic cases are associated with this. Some others see pericoronitis, but it's typically a lower molar that leads to a real significant hospitalization event. I show you this example from Nigel Johnson, and this is from the Royal Brisbane here. So we have every week patients that come from rural Queensland with the helicopter and look like this. So in this particular Finnish study, they had a retrospective analysis of a larger hospital of about 330 or so patients, and they had 168 cases that fulfilled the criteria for this particular study. Let's take a quick look at the outcome here. 2/3 of these cases that had serious health consequences in the hospital had apical periodontitis. As I said, most mandibular molars, and the risk factors are listed here. Not surprising, diabetes, overall oral neglect, and so forth. And it underlines the need for regular radiographic checkups. In the typical longitudinal studies have questionnaires and maybe an oral investigation and whatnot, but almost never are there radiographic analysis being made in these studies. There's 2 in Scandinavia, but certainly not here. This is just the large table that they have, and I just want to highlight this here. And there's 24 ICU patients. The vast majority of those from apical abscesses. Again, is 24 too high a number? Or is it a non-problem? Are we barking up the wrong tree here? I guarantee you, if you're one of the 25, you're thinking it's a very serious problem. All right. This is a bit more different approach, because we don't have a good handle on what endodontic medicine is like. I worked with Delphine Marais in France on this paper, and the question was, is there really a realistic cause and effect relationship between apical periodontitis at whichever stage it's in and overall health? Segura Eguía in Spain has coined this particular term, endodontic medicine, to kind of catch up a little bit with periodontics, who has talked about periodontic medicine for quite a while. There's currently no evidence for a causative effect of apical periodontitis on systemic health. Again, I noticed already that our perio guys are not here today, but even if I read very carefully the perio literature, I have a hard time understanding if there is or there isn't a clearly shown rather than hypothesized cause and effect relationship that says treating marginal periodontitis improves oral health, specific health conditions. And there's a lot of literature that tries to do this, but even the most educated papers that I have read show that it's difficult to pinpoint this effect. And we do very similar things in endo. This is out of Thomas Quist's group in Gothenburg, and they have a case control study here that's quite interesting. 800 cases and match controls. The 800 cases had to have a recent cardiovascular event, in this case, myocardial infarction. And then they looked at the panels and tried to correlate some oral health conditions with the cardiovascular event. And they really massaged the statistics a lot and find this. Patients with MI in the history had fewer teeth. Not really that compelling, and a higher caries status compared to controls. They had higher odds of primary apical periodontitis. The odds ratios are somewhat not quite as sensational as you would like to see, and a more root canal fill teeth the same. Endodontic infection may contribute to MI risk. Last time I looked, there's more than 400 risk factors for MI, and this is one of the 400. To a small extent, it may or may not do anything really. How about preventative? This P is important. How can we prevent disease initiation? The major etiological factor is caries and associated microbiota. Trauma is a different story. I'm not going to be able to talk about this. But certainly we can take a look at factors that are at work in caries prevention as a preventive factor for apical periodontitis. How to prevent disease progression? This has to do with restorative factors. How can we control microbial challenge? How can we initially, of course, be antimicrobial effective, but how can we preserve this effect in the long time, and this is a restorative call to action. How can we prevent general health effects? You really have to have the regular checkups that I'm asking for, and that has to be done almost in the shotgun approach because of the very high disease prevalence at the moment. This is interesting. So this is 1974, right? And Louis Grossman is the godfather of modern endodontics in the US, and he has this paper where he says this: the future must emphasize the need for preventive endodontics, but preventive endodontics is meant prevention of pulp disease. Ideally, this will eliminate the need for endodontic treatment, except in the cases for problems resulting from traumatic injury. Pragmatically, it means preservation of the natural dentition by all means possible. This is 50 years ago, and it's very modern. And so I think this is something we need to keep in mind. And this is Helen. I think Helen is on the video call. And so shout out to you. Very nicely done, vital pulp therapy. This is how we want to do this. And it's important because of this diagram here. Global success of what we do reduces from the therapy aspect, from vital pulp therapy to the more complex endodontic treatments. Why is this, right? We'll see. But the consequences are quite significant because the cost explodes towards the right. And by the same token, the number of patients that can benefit from these treatments is much reduced to the right of the diagram. Now, what's the deciding factor? That's this line here, where the drop is precipitated by microbial ingress. So really what we have to do is prevent microbial colonization and deep penetration into the root canal system. Not rocket science. Now, how do we, if we want to approach really a true P4 kind of medicine, we have to look at the personalized factor. Each canal, first of all, has to be taken on its own merit. You know this, that's trivial. So we do imaging and cone beam CT and what have you. Now, does the microbial challenge vary? Not very much. We know that there's many hundreds of different bacterial species in the oral cavity, and there will be a somewhat random collection of particular bacteria per patient, but all of them in aggregate can cause apical disease as a mixed flora. Obviously, immune responses vary from patient to patient. And that's something to take a look at. This regulation model of oral disease doesn't really fit in endodontics. But maybe genetic profiling is helpful. Let me show you something in a second here. Out of this, the notion of personalized endodontics have been floated, and they talk about genetics versus epigenetics, and this is something that appeals to the audience that I see here sometimes, perhaps. And another notion that is quite interesting is the one of digital twins. What are digital twins? So I don't know. I don't see too much digital twin. No, physical twins.
They're all different.
So this is a paper out of France with Reinhilde Jacobs on board, and she is a radiologist in Belgium. What they do here, this is a review that looks at evidence-based dentistry, where you really have to deal with global findings. Cohort in the cohort, certain treatments have performed well, as opposed to a patient-specific treatment, very individualized. What's the state of the art? Quite interesting. They do, because of where they're coming from, focus on imaging and biomechanics and very technical failures. Technical failures are very important, obviously, but not really the only thing that we are interested in here. But this is where the digital twins live. Let me show you the digital twins. They introduce all kinds of other interesting things, AI notwithstanding, but really don't talk about biology. So all of this is in the dental materials sphere, right? They can construct finite element analyses and try to predict the longevity of a restoration, for example. You know, we know many of these things, but it's a lot of unknowns also even in that. I do believe something like this will happen, and the school is investing heavily now in digital dentistry. Finally, this is the right thing to do, but it's not sufficient. It's necessary, but not sufficient. So that's not the path I see for precision dentistry, or certainly not personalized endodontics. How about this one? Biomarkers, right? We all think about biomarkers. We published this quite a number of years ago, and it's how do we collect the fluid from pulpal conditions? How do we manage this apical inflammation? And there's a recent paper, this just came out now more than others, that see utility of interleukin 8 and TNF alpha, which are global markers in inflammation. in our review, we didn't find any of this useful. Okay, so we'll look at different collection sites, and you can do this more precisely once you have access to pulp chamber. But that defeats the purpose, really. You would like to be able to do this without drilling a hole into the tooth, right? So this is something that is been done at other locations, and this is just single nucleotide polymorphisms, where they look at molecular targets in this sphere. And in endodontics, maybe. So this is Ariadne Letra in Brazil with Garland, and they're doing a couple of interesting things. So look at the current strategy. We have a conglomerate of patients. Everybody receives the same kind of treatment, and we have 3 different outcomes. They may be okay, they may have no consequences, and they may also be detrimental. With any kind of understanding of why this may be the case. So I'm just showing you some wind polymorphisms here, and in controls versus lesions, we have a significant difference for this particular polymorphism. That doesn't differentiate active versus inactive lesions, meaning deterioration versus no deterioration, pro-healing phenotype, some stationary phenotype. But the vision clearly is to be able to look at precision diagnostics at that type of level. You need to draw blood from the patient, understand very clearly what the genetic makeup of the patient is, to provide a treatment that is actually personalized and benefits with a high degree of certainty a particular patient pool. This neglects, of course, epigenetics, but we can deal with all of that. Now, should we? That's the big question. Should we? Personalized endodontics is this is Seb's case, and we can do so many things on a one-to-one basis. This is a patient that has an extraoral sinus tract and had this for many years and was significantly impacted by that. And Seb was kind enough to show me what he did. And it's very nice. We take all the precautions, we analyze the individual scenario. So in this case, the outcome is like this patient is happy for the first time he can shave properly and everything is good on that side. You wouldn't believe that this exists. It does exist, right? It does exist. So it is very personalized already. Is this good enough? I'm not sure. The world is moving in a bit of different space right now. But what is important is this, participatory. That hasn't been focused on really, but I think there's a clear focus now. Healthcare is reflected, and maybe that's the reason healthcare is reflected in social media. Patients come in with Dr. Google information, and they have all kinds of preconceived notions. At the same time, healthcare is a commodity. You know, this is all equal for everybody. You can go to the supermarket and buy an aligner. I don't see any also people here. Buy an aligner or make your own aligners, right? Is this what we want? What is critical though is educated, sophisticated consumers of health. The buy-in engagement is critical for prevention. If patients realize that they are makers of their own destiny, they will come. They come. And that's possible. Home care can play a big role. So I've seen intraoral cameras for home care that are connected to an AI tool that can show a patient what kind of disease is occurring and is changing over time. Thinking of simple things like gingivitis or occurrence of a cavity. Like using a toothbrush. Maybe this toothbrush could have a camera built into it, and then going forward, patient would be engaged with this. Considering that not every person, hopefully not here, but every person out there has their own toothbrush. I'm not quite sure this is actually true. So as I was saying, the sophisticated consumer, we work in this environment where we have wearables, the metaverse of the Internet of Things and so on. This is here already. Lots of things are already engaged in this. I'm just showing you a snippet of this, right? This is oral sensors, right? Health management based on the oral cavity. And there's a whole bunch of sensors that could actually work in the oral cavity. How good would that be? You get a new restoration. The restoration has already a sensor built in that tells you when the restoration is beginning to leak. Something like that. And a bunch of other things. This is a review, of course, but they do go in all kinds of details, including salivary monitoring, pH, bite force measurement, food intake, osseointegration, and so on. And there are lots of things. Implant could measure its own osseointegration, right? So that's possible, but it's not easy. It's a very harsh environment. How do you even make this work in terms of having a battery on board of the sensor? You know, if you can actually make all the Israeli pagers explode, you can probably put a battery into this as well. So no, it wasn't Israeli ones, but I don't know, maybe they were. So people are working on this. Is this what is going to happen? I guarantee you this will happen. The same way you have an Apple Watch and it tells you what your kind of health behavior is, this will happen. Should it? Okay. What do we take from all of this? You know, what do we take from all of this? The cost is significant. There's a notion of all-for medicine, which means overtreatment. Right? All of these individual things, does extensive testing lead to overtreatment? Is there a thing as too much dentistry? A lot of dentistry that we perform is unfortunately incentivized by money, right? Not by having the patient's best interest in mind. There's a bunch of different things. This is about Hopcraft in Australia. So patients prioritize other commodities. Right now, we're looking at a cost of living crisis. So patients are financially conscious and they delay, not consider treatment. Over and under supply of dentists can coexist. As the financial framework, incentives that drive behavior, both on the side of the patient and on the side of the dentist, have to be considered very carefully. And real world transactional relationships incentives is the header here in any fee-for-service system, as it is here, as it is in the US, and for the most part in Western economies, does not favor health outcomes. Any kind of per item payment looks at how much production you consider doing. And to be honest, we're doing the same here. Yeah? Have we actually known, have we tracked that the patient is healthier after that? So when I talked to a Danish restorative dentist, Ole Feierskov, who is very well known in the restorative world, he has said very pointedly, nowhere in the world have patients actually gotten any healthier by dentistry, except for in Denmark. So, Ole, how do you know this? He said, because I did it. So that's kind of how this works. But he can show that the number of patients that come in with caries has greatly reduced. I mean, I know that you're working on this and you're monitoring this much better than I do, but I can only tell you what all the Feierskov has said. Changes in remuneration system are essential for behavioral changes. You know, I give you an example. Block grants, for instance, for pediatric dentists that have the notion that you have to keep 1,000 patients healthier without particular per item remuneration can work. This was floated at an IEDR conference in San Francisco a couple of years ago, and the individual clinicians would say, we don't want this, because how am I going to pay back my student loans? You know, so this is a hot topic. I give another example. In Switzerland, it was introduced to have a warranty for restorations, 8-year warranty. And the dentists would remunerate it very gracefully and very kindly so that they can produce excellent work. The dentists would agree to that because they could produce this type of quality work. So these kinds of things are possible, but it's very much an outside finding. And this is interesting. So as my postgrads know, whoever is on the call, I'm interested in microeconomics. And microeconomics, a lot of social behavior is driven by, can be explained by microeconomics. So the Pareto principle is a very well-known 80-20 breakdown. It's not necessarily microeconomics, but we have to think of what do these things mean, because they are principles for decision making, resource allocation, and that's daily job. We don't have enough resources for almost everything we do. This has been researched by Falk Schwendige, and I'm getting close to the end. I'm thinking I'm making it on time so we can have a couple of minutes to talk about this. Falk has talked about cost effectiveness for a long time. And I think it's important to think of this not necessarily in dollar, but in or euros, but in effort. Yeah. What's the right thing to do is driven by how much does it cost time, effort, and whatnot. So with deep caries, should we risk a pulpic super exposure? Should we perform a re-entry operation or as a root canal treatment right away? The most predictable and in aggregate, the best way going forward. And here's a couple of answers in a particular socioeconomic system. This is from the German public system. So we're only starting doing this, doing these analyses because we have been compelled over time to hold ourselves to an ethical standard and to some kind of ideas that are centered around the patient. But also look at our outcomes and consider evidence-based practice. Now, let's go and take a look at details, right? The ultimate outcome expectation, as I was alluding to earlier, is a health improvement. Okay? How can this be measured? This was floated for the FDI by in this paper by Glick a couple of years ago. He was the dean. He's an oral medicine specialist. Was dean at Buffalo in the U.S. And you know, this is all good, all fine. But what does it really mean? Is it measurable? So I made an endeavor. Try to conquer the unknown a little bit more and try to stage and grade endodontic disease, which is kind of the holy grail in our scenario. This is copied from my whiteboard in my office and hasn't been peer reviewed, so don't take it for the gospel. So we're trying to do this in a simple way that is meaningful for risk understanding and for treatment provision. So we have stages that start in all the beauty that we have with pulpal apical health. First, we have pulpal disease, and then we have apical disease. And we have modifying grades for each of these. And I'm just putting this in here as a general idea. It could be either chronic, if you will. It could be stationary, or it could develop into a pro-healing or a pro-expansion or deterioration phenotype. Then we have characteristics that we can try to pinpoint certain conditions still. Not having the best possible physical detection tools, we still have to work with subjective things. We have to use clinical presentation, radiographs, and so on. But there will be objective detection tools developed. No question about it. So that's kind of a very broad kind of understanding of how this will work. And I promised you some of these tools. So this is already very clear. MRI systems have utility for dentistry. This is not standard at all because it's radiation free and the data can actually give you information about soft tissue conditions with appropriate resolution. The diagnostic yield in relation to field strength is unknown. The typical MRI field strength is 3 Tesla, maybe 5 Tesla, which means nothing, but the more magnetic field strength you give, the more artifacts you also create. And the higher field strength render metallic objects non-transparent. So our working assumption at the moment, and I work with people at the central UQ campus on this, is to decrease field strength and go to ultra low field strength. But that's not for today. This paper here just talks about this year as well. Is this realistic? If you really look into MRI, MRI is negatively impacted in its utility by two things: too expensive, and legally you need a radiographer to make the imaging, to make the images. That is not feasible in the dental practice. It's possible to use this in image centers already right now. And this one, the unit that they're describing here with this image, is the dental dedicated MRI that's being commercialized right now. Siemens Healthineers has this machine. So we're absolutely at the cutting edge of this. There's only 2 machines installed, one in Aarhus in Denmark and one in Minneapolis in the US. But if you look at this, you can, even with the standard T1, T2 settings, you can actually visualize apical periodontitis for this particular premolar differently. And you can actually predict what the healing progression is with this type of imaging. So clearly, this is going to happen. Give you a side note how far behind we are. I was in Beijing last year, and Peking University has an endodontic clinic with, or endodontic department with like 6 or 7 endodontic clinics, each with 10 microscopes installed, and they have an MRI in the endodontic department. They installed a 7 Tesla system because you get crisper images with a higher field strength. I told Wang, the lead, that she shouldn't be doing that, but she didn't listen to that. Why would she? Now, the concept behind optimal health is lifelong care. Nothing is done before the patient passes away, right? It's not like you have the banner, it's the finish line of a 100-meter race or marathon for that matter, but it's a lifelong dedication to care. And endodontic disease is both pulpal and periapical inflammation, and the microbial nature is well supported. And decision-making is the key in a daily practice. What do we do? Do we leave it? Do we intervene? What kind of level of intervention do we select? And ultimately, it comes back to the one-on-one relationship. What is for this particular patient the best therapy, right? And there's a bunch of different factors, and we can take all kinds of approaches to that. And time will tell what's the most efficacious approach here. And that's under the lens of cost effectiveness. There's not two ways about that. And practical means prescribing root canal treatment like this will happen by default in many practices. Post and core and full coverage is certainly not the most effective treatment. We don't learn anything if we don't show things, and this is originally made for an endodontic audience, if we show things that are not necessarily very, very positive. So beautiful words, right? Targeted approach, shotgun approach. This is a case that I worked on, and this is terrible, right? For anybody who's worth the salt, and the person they will say, what happened to him in this case? This is a patient that came to me with a root canal treatment that had been performed 8 years prior. This tooth, everything that had gone wrong in the initial treatment had gone wrong. Very nice gentleman, actually from my home area in northern Germany. And he says to me, can you not do something to work on this tooth and salvage this tooth? So I put a lot of effort into this tooth, and he sends me this radiograph last week, 13 years after my intervention. So we got 21 years out of this tooth, and he says, I feel this tooth is perfect. You did such a great job. And I said to him, I don't think this tooth is very good. I think it's time to say goodbye to this tooth, right? He said, nah, really, do I have to? Well, you don't have to, but you should. So it's really the question of a glass half full or glass half empty for many of the treatments that we perform. This gentleman is now in his late 40s and came to me, of course, mid 30s. And, you know, the pocket is different. Maybe he can afford an implant now. Maybe we get another 10 or 15 years out of implant life expectancy after implant installation is delayed by 15 years or 20 years even in this particular case. So it's not the radiographic appearance that decides what the ultimate outcome is. So what is optimal care? On the individual level, it's improved wellness. This, for my patient, this was improved wellness for him, irrespective of the strategy. And this is typically based on an intervention action, or I should say non-action. On the population level, really it's a prophylactic approach that we have to get better. From caries to trauma prevention. So those of us here who have children in grade school or any place, I can only say we got to go to the school and give them a trauma kit. For anybody who has a tooth avulse, to be sure that this is going to be okay. I don't know if any of you has kids in that particular age bracket, but these are important. Prevention of pulpal breakdown, bacterial ingress, and so forth. And the strategy needs to change to achieve this. This has to do with money. There's no two ways about this. And maybe the notion of P4 will help, but certainly, and first and foremost, the notion of participatory care. This is, I think, getting to the very finish line here. And there's a very fancy diagram that I adapted from the Perry of Friends Corman 2017. And you know, you can do a lot of good things within the framework that exists already. But we have to be able to delve into somewhat unknowns. I'm thinking of genetic typing and imagery and so forth, in order to get to somewhat of a next level in the things that we do on a daily basis. In order to be able to do this, imaging has to be better. Yeah, do we require a cone scan for every patient? No, we don't. But we know now that images can be, from their dosages, quite low. So the threshold to perform that type of imaging will drop, so more images will be taken. And we can also do functional mapping of tissue conditions. And while we couldn't get the right markers extracted with the solutions that we had at our disposal, we can get better at that. And this includes MRI, of course. I don't think there's too much to be done on the microbial side, just because an ecologic equilibrium will occur for our patients based on certain chance scenarios. That's going to be the case. I don't see a practical way of changing microbial load. We have tried this, and we can talk about it maybe if somebody is really interested in this in the question and answer period. But there has not been any sign that a specific low number or individual microbes are decisive in endodontic disease, nor has there been any individual cytokines or 2 or 3 cytokines emerged that are decisive. It's a non-specific clinical condition. And we have some similarities to other diseases from which we can learn. I hate to admit, but it's true. Perio is 10 years ahead of us. But it also means we have 10 good years ahead of ourselves. We talked about management versus treatment. We talked about oral health. The issue is that the physical constraints that we work in are very different. There's the ability in the perio situation for exchange of solutions, exchange of fluid, exchange of bacteria. We don't have this. We have also a much smaller scale. So in other words, as Dennis Benet would say, the wound surface is much smaller in endodontics than it is in periodontics. And that makes it good, but makes it also very difficult to access. For now, I thank you very much for your kind attention. It was a little bit of a rough start, but we got to a beautiful finish line. And I'm happy to open this for any questions from the audience locally here or online.
We do have one online from Ping Ping. I'm sorry.
I work for food, I tell you.
Ping Ping does have a question online. Ping Ping, are you available to
You can show yourself.
yeah, you can.
Before I do this, I just leave this on for a sec because the slides, you can download the slides from this QR code if you're interested. Otherwise, just email me and I'll send you the slides, okay? Because then I'll go out and stop sharing so that everybody can see each other.
Ping Ping's question, she totally agrees with you in regards to that. It's definitely the future for dentistry. She also mentions, what do you think is the best tissue or biosample source for P4 endodontics? How can we track individual epigenomes given the epigenome profile is dynamic after lifestyle, stress, and other environmental factors?
Wow, there's a lot of details and a lot of questions. So from a fluid, consider there's 2 things here. If you can determine the tissue condition prior, like as a screening test, prior to intervening, it has to be without any, let's say, physical drilling or blood draw or anything like that. So the only way to do this is to try to extract pulpal fluid across the final tubules, which is very difficult, but it's possible. Once you open the pulp, that's the current way of doing this, is you open the pulp and get blood. So we have blood samples and we'll go to and analyze those, but that defeats the purpose to have either a non-invasive or minimal invasive scenario. We have tried to use sulcus fluid, and the problem with sulcus fluid, as you clearly know, Ping Ping, sulcus fluid is contaminated by periodontal inflammation, infection, and what have you. So it's very difficult to make use out of that. So right now, I'm not seeing this as the approach for a standard testing regime. Testing regime, screening, and point of service prior to intervention. Remind me what the epigenetics.
Epigenetics, yeah.
I'm a little bit at the moment, a little bit in the O4 camp for this. I think epigenetics at this moment is taking it too far because of 2 reasons. A, the prevalence of 50% of all population having apical periodontitis is a bit more towards a shotgun approach. Right? So intervening, we have to. So what we have to figure out a little bit more is, are there distinct differences where a patient that has some kind of hyperinflammatory phenotype in pulpal disease is responding to certain things better? Ask me again in 5 years, maybe in 10 years. But thanks for the question, it's very important.
Do you have any questions here? Don't be shy, ask questions.
No,
Very, very good.
that's also good, but I have all the answers, that's good.
I think Laurie's got one online.
I was gonna make a comment actually. This idea about changing a health system by having people guarantee their dental work, they've been doing that in Thailand for a number of years. And so Thai dentists are supposed to guarantee their work for 7 years for Thai locals. But guess what? It doesn't apply to foreigners. So when
Yes.
foreigners fly in to have dentistry done, there is no guarantee. So there you go.
This is almost like, I don't know what kind of testing they have done, passport testing maybe, no, but I did not know this. So is that for
Yeah.
any type of treatment, or is it for particular for restorative?
No, that's for practically everything. And so this has actually driven the growth of tourism dentistry because you don't have to worry about the guarantee.
Yeah.
So when you change a system, sometimes there are perverse outcomes that you don't anticipate. So it's always a bit of a caution that you need to preempt what people might do that's perhaps against the general direction of what you're trying to achieve. Yeah.
Yeah, no, I hear you. This is very interesting. Unintended consequences, right? But look, I mean, the fact remains that that type of environment or changes in that environment will drive behavioral changes. And I don't know. So it could be milder than that. It could be that you get a fee after you complete a treatment. And if the patient is asymptomatic and the tooth is still there after 5 years, you get a bonus, right? So we need to work with the health economists to understand a little bit better what works best in this. But this is such a holy grail. Sometimes it's I don't want to. I'm not afraid to touch a hot potato, but that's probably too hot a potato.
Yeah.
So I have a couple of chat things here, actually quite a few, but this is probably all complained about.
No, that was, we've been monitoring those.
Ping.
Yeah,
Oh,
that's-
you were.
yeah,
Very good, even better.
yeah. And most of it was just, that's all good. Any other questions online or here?
And the comment as well. So as
Yeah,
I am
comments,
a
yes.
population person, a health person, I said, very pleased to see an endodontist talking about value-based healthcare and prevention. That's very important because I see that the traditional endodontic treatment is a low-value healthcare.
100%.
Moving that's to higher value healthcare. That's better for the.
See, this is one of the other unknown pieces of the vocabulary that I didn't put in the value-based healthcare, but that's exactly right.
Yeah.
And I started out with this many years ago when there's a person, Paul Glassman, that you may have known, who was in our department in San Francisco, who talks about this. And if you look at simple things like comparing the US and overall, not oral medicine, not dentistry, it becomes apparent that while the cost in all Western, or most Western economies for healthcare in the last 40 years or so has doubled, in the US it has quadrupled. If you use as a general marker life expectancy for healthcare outcomes, it has actually fallen behind in the US opposed to others. So just putting more money towards this is also not going to be the solution. There has to be smart money. And there's intent to do this. And simple thing, dentistry is so unimportant, unfortunately. Is it being recorded still? Well, there was a long discussion about bypass operations, right? Every small hospital in the US is geared towards performing bypass operations because it's a lot of money in it.
Yeah.
And they do this based on AKG readings. If there's something aberrant and the patient may be asymptomatic, there's no guarantee that the patient may benefit from it, but it's a guarantee that 1 out of 2 out of 100 patients will die just for the operation. So they stopped this because it was clear that the benefit is much lower than the cost, both in lives and also in money that's being afforded. So there is a focus on this in the US much more than it is here. And so hopefully we'll see some trickle down in endodontics at some point.
Yeah. But if you were for us to build a case for the government to fund it, maybe that's the unseen cost of other treatment, like people cannot get endodontic treatment, but they suffer from that. Maybe that's something we can build as more, even more that the cost to society than that.
But this is why I put the somewhat of emphasis on the risk question, right?
Yeah.
But you know that I tried to tailor this grant towards that was soundly rejected as completely irrelevant.
But don't, you need to move on.
Yeah. No, I
Continue with that.
I'm trying to move on, but it still stings. Well, no, I haven't given up. So the way we should do this is to identify a cohort where we can draw some existing patients, and then have to build 2 forward-facing prospective cohorts out of that. Another day. Okay,
Thank you so much for your participation for everyone. Thank you, Ove, for your time. It was amazing. We're just going to wrap up the session now. So for the online people, we'll hopefully send you a full recording of that. And here in person, please stay and enjoy some refreshment. Thank you again so much.
thank you.
Thanks, Eve.
Thanks for the extra effort getting this to work. Look, it was full of surprises.
You came prepared with all your.
I came prepared as
connectors.
far as I can do, I come plug in, that's all I can do.
But yeah, that's